Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CARN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning, everyone, and lovely to see you once again. Welcome to CATHIP's Health Hour. Welcome to our regular listeners and welcome to those who are spending time with us for the first time today. I'm Dr. Vanessa Apea and I'm your host for today. And so, first of all, what is CATHIP? So CATHIP is the Caribbean African Targeted Health Improvement Program, and it's a collaborative, educative, and empowering program to really support people to take control of their health and to support others to take control of their health too. And the partnership is made up of some fantastic organizations: the Caribbean and African Health Network, the Black Health Initiative, the Royal Assembly Redeemed Christian Church of God, RAFA International Development Agency, Croydon BME Forum, and the Enfield Caribbean Association. And within the Health Hour, we always work hard behind the scenes to make sure that the topics are relevant to you, to your partners, to your family, to your friends, and to your network. And the key thing is that each and every session is for you. So please feel free to ask questions, put your questions in the chat as we go along. And at the end, I'll be managing things to encourage people to ask their questions directly. So we really want this to be an interactive, informative space. And more importantly, a safe space for us all to share our needs and concerns. So as we go along as well, it would be great if you could put in the chat where you are, your location, if it's just you or with your family and friends, just so we have a sense of who's with us today. And just to let you know also that we'll be recording. So if during the talk or afterwards when we're asking questions, if you'd prefer for your face not to be shown, that's your choice. But please do be aware that we're recording so that this can be shared with people afterwards as well. So I have the pleasure to introduce Dr. Mohamed Kamara, who is a fantastic colleague and friend of the CATHIP Partnership and Health Hour, and has been on many times, and is on today to talk about one of the commonest, but also that can be one of the most debilitating symptoms, back pain. So Dr. Kamara, thank you so much for your time, and over to you.
Thank you for having me. Thank you for the warm welcome. I wanted to find out from the audience. I can get this going, yeah. Who hasn't had back pain? or pain in general?
Whilst Dr. Kamara is getting the slides ready, please do feel free to put your answers in the chat.
Trying to get it to go into the slideshow, but for some reason I think I'm.
Oh, the question was, who here has never had back pain before?
Right. Yeah, it doesn't seem to want to do this. I don't know why.
I wonder if you just go to full screen.
Yeah,
And
I'm on full screen. Yeah, it is. It's full screen with them. I think because it's live, was maybe that's what's affecting it. Right. Here we go.
Perfect. Whilst you're doing that, Dr. Kamara, there's some interaction in the chat. We've had Jade. Thank you for sharing. I'm really sorry to hear that you are suffering from upper back pain. And we then have a friend that is on, Christine, who's saying, I'm lucky not to have back pain. But there's more interaction coming in the chat of sciatica.
That's really good. I like that. So who's not had back pain? Well, we probably would want to hear from that person. You know, it's an important aspect of our lives, that. So who's not had back pain? And I think it's a she as well. Now, interesting that, because it's common amongst the females, as we know. So I thought a few statistical points to make. Now, just when the pandemic, you know, broke out, you had over 500 million worldwide people affected with back pain. So the colleague who says she's not had back pain, well, that's good. You really something good, something really effective that the likes of us are not doing. However, roll on to 2050, in another 30 years, look at it. It's almost, you know, well, it's more than 750 million. It just tells you that in everybody's lifetime, there has to be that possibility of having it. You know, you got like 58.3% of having that possibility of back pain. And in a year, there is a possibility of it being up to 36%, you know. In England, I wanted to be just topical. Every 6 people, one of them would have had back pain. And it ranges. And this is not just within one age group, it's actually on all, you know, in all the age groups. You get that. So people, obviously it's professional as well, you know, depending on the profession you have. If you are a menial worker, or maybe somebody that is an athlete, or somebody that runs, or, you know, for a hobby or something, clearly, you know, you're more likely to have developed that than not. In women, obviously, one thing we always think is, well, hang on, because they're women, they're very dainty, you know, and things like that, not wanting to offend anyone. But there's no clear trend, and there's normally the notion that it's associated with the class system, and you know, those in the lower levels normally expected to be more afflicted. Well, that's not the case. There's no clear trend. What we know is that pre-menopause women are less likely. Post-menopause women are now catching up with the men. It's as simple as that. Now look at this economically. You know, look at what it costs the likes of you and me, or anybody who's paying taxes. Because as we know, the NHS is funded by our taxpayer system, yeah, by ourselves. So almost £5 billion. Imagine that. That's like 2% of the gross national product. It tells you how, you know, difficult it is, how expensive it is. Just back pain. I'm not talking about the other things. And when you think about it, the 5th commonest reason why people come to hospital or maybe access healthcare facilities is definitely pain, in the back and from the other regions. Now, I put this there, red flags, just for you to know that there is pain and there is pain. But, if you have pain in anything we do, you have what we call red flags. These are the, what do you call them? These are the symptoms that you look for. I mean, the name denotes what it is, a red flag. That means, it's a dangerous thing, and it's obviously something you don't want to happen. So if you've had back pain, it might be because you pulled the muscle, maybe because you were laying funnily, or maybe because, you turned around, someone called you and you turned around quickly, and then obviously this is carried on. So if the pain is getting better, that's fine. That's normally what happens. But if you have it longer than 6 weeks, then you begin to wonder, because by the time it gets to 12 weeks, it's no longer acute. It's now becoming chronic. And that's where the problem lies. So that's my talk, the second part of my talk. First part today is just the acute pain, but we'll probably top that with the chronic pain, which actually you would say after 12 weeks of the same pain. That would come later, because I cannot cram the whole talk into one session. Impossible. It just, because it's a big topic, So those under 18, especially the under ones, now the children do not do back pain. So if you have a child who's got back pain, please, the sooner you bring them to the hospital or to the GP, the better, because back pain and a child do not go together. Definitely, they don't speak to one another. So therefore, it's a no-no. Somebody older than 50, well, obviously you have different reasons why somebody has got back pain. It could be because it's coming from the belly, it's coming from the back, coming from the chest, coming from the neck, coming down from the pelvis. All over, you can get that. So remember, above 50, keep an eye on it, but don't keep an eye on it for too long, because it may well be something that you need to take care of. The sooner the better. If someone's had a fall, you definitely would expect pain, and maybe there's a fracture there. So if you don't have an X-ray, it's not likely for you to actually, unravel it or maybe discover it. There are other symptoms, like if you've got pain associated with fever, especially at night sweats, chills, then clearly think about an infection. It could be coming from the kidney, or any other areas like down in the urinary system or the genitourinary system, i.e. the female or the male, and all sorts of things happening there. So it's important to remember that. And of course, weight loss. If you are not deliberately trying to lose weight, but then you're losing weight and you've got back pain or pain in general, then obviously you need to be thinking about getting assessed. People who've got immunocompromised statuses, need to be careful about back pain, because sometimes it could herald something like shingles. I've seen someone recently diagnosed someone with that. Over 6 months, they had the pain, and lo and behold, it was shingles. So because of the immune compromised system, if the pain is at night, remember, that is not a good sign. Normally, when you lie down flat with your head or your face looking at the sky, which is what we call supine, the pain should ease because you're relaxing, you're stretching the back, the muscles ease because of the spasm that was there is now getting better. Clearly, that should ease the pain. If that doesn't ease the pain, then something else is happening, and so therefore it needs to be looked at. If the pain is not improving with painkillers, you need to think about that big vessel in the belly, which is called the aorta. It can get bigger. You can think about kidney stones, which can happen. It could be because of a lesion, like a tumor. Of course, if you're coughing or you're sneezing or maybe you're blowing onto something and you feel that pain, and the pain goes down to the knee, remember, that may well be a disc in the back that has come out, and that's causing the problem because it's pinched. And so therefore it's pinching on the nerve, and that's causing that problem, you see. But look at the last three. These are absolutely take-homes. If anybody has got that, you've got pain in the back and you've got problems with holding your urine or your wee, please, you need to be coming to a hospital in an ambulance. I tell you that. Because the bladder, if you don't look after it within 6 to 24 hours of that happening, then clearly you're causing yourself a lot of bother, because you might end up in a life of having to have, sanitary towels and pants and things like that. So I urge you, please pay attention to that. If you develop incontinence or the opposite, you can't wee, you go into retention of urine, then please ring an ambulance to bring you in. It's what we call cauda equina. It's an acute thing, it's an emergency, and it needs to be sorted out as soon as possible. If you have problems with your back passage, i.e. when you sit down, the sit bone, you'll find out later, just now as I bring it to you. If you're sitting down and you can't feel your back passage, it's like numbness around that area. That is not a good sign either. And of course, if at all you can't move the leg or the arm, it's something sudden, all of a sudden, it becomes heavy. It's like weak, like you think you've had a stroke with the pain. Because the stroke, you wouldn't have pain with it. But if you've got pain in the limb that is radiating and now you can't move it, then you need to understand that you definitely are needing some urgent intervention. So that said, I needed to probably just highlight what is this structure in the back. We all talk about the back. We talk about the spine. Perhaps not many people know what the structure is. Now, if you look at it, it's divided into sections. The neck, we all know. The thorax, which is the middle, where the ribs are. And of course, the lower back, which is the lumbar spine, where there's no ribs, And then, of course, the pelvis and the sit bone, and then the tailbone. So when you look at it, I think it's about 33 bones. So 7 in the neck, 12 in the middle, 5 in the lower back, and then the other 5, which is the sit bone, is 5 crunched together, they're fused together as one bone, and then the rest can vary between 2 to 6. The last one, which is the coccyx, as they call it, the tailbone. So the structure of the spine is that some people call it an elongated S. I take it. For me, I think I prefer 2 S's put together. And if you look at it, the neck, as I said, 7 bones, is curved forwards. So if someone comes to me and I can't see that curvature, then I know there's probably the muscles in the neck are going into spasm because of pain. Sometimes you lose that curvature. That is because of a sign of something going on, So the neck goes forward, which is a 7. They go forward, which is called lordosis. The chest goes backwards, which is the kyphosis, which is the backwards. The chest goes backwards, and then the lumbar, which is the lower bit, which is also 5, goes forwards, and the sacrum and the coccyx put as one also goes forward. So you can see the S is 2 S's for me. Neck forward, chest or thorax back, and then the lumbar and the sacrum go, the other way, as you can see. So it's important to remember that how it works. And in between them, if you look at this blue bit, the blue in between the bones, that's the disc. We'll talk about this now, the disc. That's what helps you. It's like those that drive should know it's called the shock absorber. It helps you when you go through the bumps like the sleeping policeman. And if you have one that is not very, very effective, you obviously feel your back. It jars it. So what that does for you is help you with the movements, and it actually helps you to preserve the spine, So as I've said already, this is what you have. 33 bones, 24 of those are movable, and the rest, which is like maybe 9 or 10 of those, then obviously you can't move, as it were. As I said, 5 fused together as the sacrum, which is 1, and then you have from 3 to 6 of the tailbone. That's how it is. So you need to know the role. So if you talk about the spine, what does it do for you? Now, if you look at it, you'd see that bone, it has got this body. So if I go back there, you could see this bit. So this bit is the body, and this bit is the hole where the spinal cord sits. So this is where it goes in. So if you put all of this together, you get like a tube, and that's that tube that you can see there. So it finishes around here. So the lumbar's got, you see, they give you nice pictures, colors. You can see this is gray, and it's a lighter shade. So from here to here, that's the lumbar. And from there to there, going backwards, that's the thoracic. And then from there to there, that's the cervical or cervical. And then, of course, that darker gray is the sit bone, the sacrum. And then you've got the tailbone joined there. So all of these put together, they form this tube, which is where the spinal cord nestles. So it finishes around somewhere here. Yeah, L2. And then the rest of it is just like the tail of the horse. So that's where the name was coined, or the title was coined from, cauda equina. So cauda is the tail, equina obviously is the horse. So that's why if you have this thing I'm talking about, this 3 here, cauda equina syndrome, that's it. If you have those 3 symptoms or signs, please, I need you to be making your way to the hospital as soon as possible. So what does it do? So as I say, it's got the body and it's got the arch, you'll find out. And in there, as I say, this is the cord that nestles. So it goes through there. And as it goes through each and every one of these bones, it actually gives away or gives out these branches of the nerves, which is what gives you sensation to the areas. So for you to move, you need to have that message sent. And that is sent downwards via the spinal cord. And for you to feel like you feel pain, or you feel tingling, numbness, and weak, and that kind of thing, you will definitely need it to go the other way around. So it's going upwards, you know. And of course, coordinating the reflexes so that when someone hits your knee, it jerks, or your ankle, it jerks. Definitely, that's what the spine does. It coordinates all of these. So injury to the cord, the spinal cord, will actually result in pain, numbness, tingling, and of course, weakness, you know, which is something you get sometimes with the stroke. However, you don't have any pain associated with it. So as I've said already, this is it. So the body is there, and the arch, which is all of this. And if you were to feel your back, even at the neck, you will feel this pointy bit. Although it might be covered with the ligament, but you feel it. I mean, the one that is most easily palpable is where the neck ends. So it's called the C7. And from there on, the thoracic one joins in. So this is there. These are all there to help with the ligaments and the tendons and the muscles to attach themselves to help you with the movement, you know, of the spine. So now it has got those that like those that have got sweet tooth. They know about eclairs, you know, the sweet. In the middle, you have this soft, nice pulp, you know, and then the outside of it is a bit, you know, solid, a bit hard, and it's like an adhesive which attaches to the vertebra, the bone, and then inside of that is like a spongy bit. So you've got this shock absorber in the middle, which helps you when you move, so that you don't feel pain, you don't bone on bone doesn't rub on one another, you know. And as you grow older, obviously the eclair sort of, you know, dries up. If you left it out for a long time, it will dry up, and if it dries up, obviously it's not as smooth, as lubricated as it were, and as a result, it causes problems. So that's the 2 parts of it, and that's what that does. It cushions the cartilage, and then of course it cushions the bones to the point whereby movement is sort of, you know, pain-free, is friction-free, put it that way. You know, it's like a lubricant, you know, and it helps you, and it absorbs all the shock that otherwise you'd have felt. So as we've said already, the spinal, you know, the tendons, the ligaments, and the muscles are all there to help you to preserve the shape of the double S, if you like, or elongated S, you know, and for it to work properly when it's aligned as it should. And then of course you have movement, you know, it helps you carry the loads, you know, that you actually encounter as you go about your daily activities, your day-to-day life, you know, and things like that. But remember, this is one thing we always fall foul of. Now, I don't know how many times I have to say this. The muscles of the back, people think are the strongest. Yeah, they are strong, but they're not made for lifting heavy loads. That's one misconception. And that is where the problem lies, because we all think the back is strong, and so therefore that's what it's made for. No. On the other hand, the muscles that are made for you to carry these loads, which would help protect your back, it definitely are the ones that are down in the legs, in the thighs, in the pelvis, in the abdomen. So these are the ones that would really help you. Other than that, you actually are just destroying your back. And the problem is, the back problem would exist for a long, long time before one fine day tells you, oops, I can't take anymore, and here you are. So you do damage the disc because of different reasons, you know, and one of them would be age. One of them because of habitus, like, you know, the size, the weight the person carries, you know. It runs in families. Other illnesses, you know, like, as I said before, premenopause and postmenopause, the bone becomes weaker in women, and so therefore they're prone to. And if you're not fit, you know, well conditioned, then obviously you're prone to getting that kind of thing. This is why if you watch before the footballers go into the pitch, they actually warm up, because the last thing you want is when you're cold, you go into the field and you can just end up injuring yourself. And that's what normally happens even with the women and the male athletes, you know. Yeah. So if you look at it, you can see what it looks like when it's healthy, the spine. There you go. In a younger person, it's actually nice, you know, bubbly, is nice with that eclair on it. As you age impacts on it, it begins to dry up and it begins to flatten, as you can see, you know, on the second one there. And the same there with the disc. Some people talk about it prolapsing and things like that, but obviously it's a different thing altogether. A true prolapse is very rare, as it were, because it's something that is continually happening because of bending, twisting, overreaching, you know, wrong posture and all of that. And that's what you get. You can see it actually dropping out, that red bit, pink bit, you know, as compared to the blue bit, which is well within and is really absorbing a lot of shock for you. So now, how does this happen? It is important to remember there's 4 types of, you know, forces, actions that can actually cause problems with the back. You know, one of them is tension. Now you can see from the first picture there, as you glide laterally or medially, one gives to the other. So if you're going right, you can see one goes down and the other one goes up on the left. Can you see from there? And then, of course, that's tension. So when you're twisting and bending, that's one thing you do. And then the second one is compression. So as you can see, the weight from the top going down, it's actually, you know, pressing on it. That's a load, and the axis load is on it, the second bit. The third bit is what we call shear. So shearing, which is where you are, one's going one direction and the other one going in the other direction, you know, pulling. Like, you know, you're going one way, the body is one way, and then the other bit is going the other way. And then the fourth bit, obviously, is torsion, where it's twisting, which is something we do, sometimes dancing, sometimes running, sometimes training, ballet, you name it. All of that is cumulative. That's the word for it, cumulative. It, you know, it adds up, drips and drops and all that. And then one fine day, oops, the back gives in. But it would have been there pre-existent, especially if it runs in the family. So what are the causes, or what are associated, you know, signs and symptoms of a sore back or a painful back? Now, the simplest thing that can happen is you pull a muscle. I had someone tell me that, you say, my back, I don't know, what can you advise, doc? I said, what's happened to you? He said, I don't know. I said, really? I said, okay, have you injured yourself? He said, no. I said, maybe you've lain funnily. And he said, oh, doc, and you're a genius. I said, what do you mean? He said, I tell you what, the grandkids came and visited me, and they were all so excited during the holidays that we were all just crowded in, you know, on one bed. And there were like 5 of them. And obviously the space was tight. So normally when I lie in the bed, I would turn around a few times in the night, you know, just to get comfortable. This time I couldn't. I just laid there. And since then, I've noticed that I've got this pain. So you can pull a muscle, which is what this guy had done. And of course, some painkillers, correct posture, some massage and things like that, and it got better. It could be an inflamed muscle. And as I said, wait for this, this is arthritis. Now, I'm pleased the colleague that said she never had back pain. Well, I tell you what, maybe she's not 50. But every spine, this is scientifically proven, every spine at the age of 50 would have some amount of arthritis on it. No questions about that. This is factual. It might be less for some, it might be more so for some, it might be moderate for some, but clearly at 50, the spine would show signs of degeneration. There's no questions about that. More so if you got osteoporosis, which I talked about already. Osteoporosis is not just related to postmenopause. It could be an illness in itself. You know, osteomalacia and osteoporosis is something you can get. The bone is weaker, and so therefore it can break easily. Therefore, you know, it can damage easily. Obviously, wear and tear, you get the discs, you know, coming out, protruding, and they dry up, and they can easily lend themselves to that kind of thing. Stress is added here, but that's more to do with the fact that stressful situations would actually trigger the back pain, which would have been playing up, which have been there, you know, accumulating all this while, and then the stress just triggers it. Fibromyalgia, well, that's a term which is non-discrete, put it that way. It's so broad, difficult for anyone to tell you that or not. But obviously, that's one of the things that they associate with this back pain, and pain all over the body as well. Which brings me to this. So the likes of us who are employees, or the likes of us who are employers, this is not, what's the word for it? An alien term, or, you know, Just look at it. I think if you look at it, maybe it sounds familiar or it looks familiar. Look at the first photo. See where the big red X is and compare it to the green tick. You would see the difference. And I think we're all guilty. I am guilty, I must admit. There's something you don't pay attention to. And then all of a sudden in your 50s or 60s or 70s, oops, these things happen. When you were younger, you didn't pay attention to that. And people will still continue to do it. So if you look at those pictures, you would see the right way to lift, the right way to carry, and the right way to actually push. You can see that. So what is a load? A load can be a human being. It could be an inanimate object, And as long as you're getting involved in that and you're supporting and transporting or moving or whatever, you are definitely taking part in manual handling. So if you're lifting, do it as you should, as the picture shows. If you're putting down, do it as the picture shows. If you're pushing and pulling, do it as you should. And if you're carrying or moving by hand, by bodily force, remember, there's certain things you need to do. The weight is something you need to assess, something we call risk assessment, which brings me nicely to this. It segues nicely to this. So before you undertake the task, think about your back. I don't know how many people do it, but not many people can tell me they do that, because all it is, the boss wants me to do that. Well, the boss has got responsibilities to you as well, and you have responsibilities to yourself. We'll find out later. There's legislatures there that would actually protect you, and of course, the boss needs to take into consideration. So the factors you need to consider before you undertake this task are, you need to look at the load. This load, is it something that I can do on my own, or I need some support? Because obviously there's certain weights I can carry with a full arm or half arm, and depending on the part of the body where I am, I could actually do that on my own or not. And remember, the golden figure is 25 pounds. So anything that weighs 25 pounds, imagine that you're taking and pulling and pushing and dropping 25 pounds. If you do it more than 25 times in one day, which is very likely because of the kind of job you do, you're more likely to develop back pain very soon, sooner rather than later. I can tell you that for free. So the environment you're working in, that might influence the effect of what that load would be like. If it's too tight, if it's slippy, all of that you need to take into consideration. And of course, your ability or your capabilities. I remember a colleague who was supposed to be handling somebody's neck because this person fell through the roof, and the person came and we had to move this person from the trolley to the CT scanner to see what's happening to the bones. And this guy, lo and behold, had an injured elbow. Didn't say that to anybody, didn't tell anyone. And so obviously it became a problem because he felt the pain and therefore dropped the man's neck. And that created a big problem. So please remember, individual capability is absolutely vital. There are other factors, including the kind of equipment that you're carrying. If it's sharp edged, if it's really heavy, if it's cumbersome where you can't get around it, then remember, you need the support, you need the assessment for it. So what are the factors that would influence the development of the back pain? Well, as we said already, the posture, which we all know, especially us blokes, us men, we slouch, Important to remember that poor posture would give rise to problems with the nerves and the muscles. When we're lifting and pulling and pushing and lowering, we're causing damage. This is because of the mechanics of the body becoming faulty. The living habits or the working habits, if we're in a stressful situation, obviously we don't pay much attention. And therefore, we're prone to injuring ourselves. If you're not fit, poor physical condition, as I said, and you jump straight into it without easing yourself into it, you will probably end up injuring yourself. Well, of course, age catches up with all of us. It weakens the spine. And as I said already, that makes it, you are more vulnerable to injury than not. The weight we carry, that doesn't help either, and of course, wear and tear, as it were, rheumatoid arthritis, osteoarthritis, and all of that, and of course, injury, depending on what you do in terms of like the profession, But I wanted you to pay attention to this last sentence, that the episode that you have now, which is the back pain, it runs its course. However, the important treatment, this is the treatment that you would actually do for yourself and for anybody else, becomes the prevention of future episodes. So if you prevent the episode of the next pain, then you would have been doing yourself a world of good. Remember, the back disorder begins to develop way, way, way before that pain, and it will still be existent after that pain subsides. It's a very, very important statement there. Yeah. So as I said, it's been there, it's been latent, it's been dormant, but now it decides, to come up because of what you've done. And if you don't look after it now, the second one will be even worse, and the third one, if that's to happen. However, if you take control of it now, that's what this is saying, then you will actually do yourself a world of good. So, don't know, those that work, you will probably be familiar with these aids and these, the hoists, care homes, the toileting, the beds in the hospitals, and obviously even at home, the wheelchairs, the trolleys, the tripods, the crutches, the walking sticks, and even the trolleys, which you think are, I'd say injury-free or maybe not harmful. Well, I tell you what, there's a lot of harm that could be done with that. So these are the things that we need to be really careful with, when we're working with them or when we're, doing things with them, especially with the human being or anything else being on it, So how would you, preserve your back as you grow older? And that's what I wanted to come to. That's important. Remember, you need to look at what is called the center of gravity. Now, if you look at the picture there, you'd see it's right there in the middle. The moment you actually push that away or maybe displace that, you're now exposing your back to that problem. So look at it. If you look at the picture on the right, you see this person is slouched. It looks like a woman, but maybe men are more prone to doing that. Look at it, they're slouched. So the center of gravity is moved away from that pelvis region, is now higher up in the thigh. Whereas you see the woman on the other side as the extreme, because her center of gravity is actually right there where the ball is. You see when she's moving, she's using the levers, the arms, to actually lever herself to the position and then from there stand upright. That's vital, because when you miss that, this is what happens. You now lose that line of gravity. You see how on the left there, look at the big red one. That's what we do all of the time or most of the time. Look at where the center of gravity is now, compare that to the right, and you can see that the external levers are short. Yeah, they help you sort of preserve that back. But as I say, it's a cumulative thing, because once you fall foul of doing what you do there on the left there, you would not get any notification until it actually becomes too much for the back, and so therefore it gives in, and then now you have the task of trying to get it back to where it was, which can be challenging. So this is just a sort of a presentation, if you like, telling you what you can lift. Again, it's risk assessment, which you can get at full arm's length or at half arm's length. It varies with the gender, it varies with the height, it varies with the weight. As you can see, if you're looking at full arm around the neck area, you're looking at 3 kilos. And, half arm, obviously, you're looking at 7 kilos. And for the man, obviously, it's a bit more than that. So it's just something as a guide, which would help you to actually get yourselves, in a better position with your backs. So, this brings me to this. Brilliant. Look at this. I think we're all guilty of this kind of postures. We want to help, especially us, healthcare professionals. That's what we do. Look at that. These are all controversial. They all end up causing us more harm. And we're not. I can tell you this, they tell us we're not insured for that. This is why they always tell us we have to do manual handling, the courses. We have to do it repeatedly because it becomes mandatory. They don't want to be coughing out. They don't want to be paying out money, because we ended up injuring our backs while we're working. That's why they'll always tell you need to do it the proper way. If we look at the top two, the drag lift procedure or method, someone is on a wheelchair, you have to bring them up using that. You see how they're working away from the body. The center of gravity is completely lost now, so you're dragging. Although there are 2 of them there, but again, look at them crouching, look at them bending, away. If you're using the front assisted method, again, the one foot is in the front and the other one, but you can see that person's weight is now being moved towards you. And so therefore you'd end up, injuring the back. Again, the orthodox lift is again controversial. So are these ones, for some reason they call it the Australian lift. You can see they've used their knees and their legs and of course their backs, and the patient is actually resting on them for them to get them upright. That is not suggested and that's not recommended. You want to do it on your own, you want to go through the arm and lift. Again, you're working away from the body. The center of gravity is completely lost. The arm and leg log, which is the hammock transfer, again, that has it poses problems for the back. And so does the bear hug, as you can see. These are all controversial. So what do you do to preserve the back? When you're faced with this, you need to think and plan. Do you need help or not? Plan ahead or plan whilst you're there. The feet, adopt a very stable position. Be prepared to move the feet during the lift to maintain stability. Remember, if you're moving the body, the feet have to go with it, or the legs have to go with it. The arms have to go with it. The postural stability, make sure the spine is in line. One leg slightly forward to maintain that balance. The grip, remember, the pulp of the fingers is meant for feeling, so they sweat, and so therefore it can slip and that can cause a problem. Remember to use your hands rather than the fingertips. Consider what you're going to do. Are you going to go round the block? Are you going to go straight? Are you going to go direct? Or do you need support? That kind of thing is absolutely vital. And of course, the environment. Is it clear? Is it tight? Is it narrow? Is it constricted? Is there traffic and things that, you don't see and all that? Absolutely. So, environment, we talked about already. The feet, remember. What position are you starting from? Slightly bent knees. Don't let them straighten because you don't get, the power that you need to lift from the knees. The hand position, remember, has to be between the waist and the shoulder level. The grip, not the fingertips, as I've said already. Posture, the spine has to be in line, center of gravity. And of course, remember, that test is important. Is it too heavy or not? If it's too heavy, then please, there's no shame in seeking help, support. That's what we're there for. We're a team. Push action, stand tall, use your legs to move you forward, and the arms slightly bent at the elbows as a walking motion. That's the only way you can protect your back. Consider backwards. But the danger of coming backwards is that maybe you might not see who's coming or where you're going. And so you can easily maybe run into something that can cause you more problems. So the 7 principles here that you need to consider. So stop, think, and decide what you want to do. And of course, remember, prepare for it. The preparation, as I say, it's all in the preparation. The proof of the pudding is in the eating, because you would have actually made efforts to prepare it in a way whereby everybody would enjoy the eating. Remember that. And of course, the base should be stable. Remember, not the tips, the fingertips, it's the fingers and the hands. You need to close the load. And of course, you need to use the muscles. As I say, off the thighs, not the back. The back muscles are strong, yes, but they're not meant for that. And that is why we always end up injuring ourselves. And of course, if you are in a team and you're trying to complete this task, then clearly you need to have someone who is the leader, and they will be giving you clear commands. The commands have to be clear. They don't have to be ambiguous. They don't have to be muddled. Otherwise, there's room for accidents to happen and injury to take place. These are the legislations. 1992, this was actually because of the risk management assessment. And of course, that was brought into action. It's now law. So what you must avoid, what you must assess, what you must reduce, and what you must review, they're all there. And there are others as well. In 2006, Management of Health and Safety at Work regulations is there. So for those who are employers, this is something you need to know about. For those of us who are employees, this is something we need to know about as well, because obviously you've got rights and so are the employers, but you need to fall within those rights. Remember, 1998, there was lifting operations and lifting equipment regulations. They're there. You can Google them, or you can go into the websites, the government websites. They're there for you to help yourselves, protect yourselves, Even the use of equipment, there's a regulation there in 1998. So that brings me to the take-home point. Remember to reorganize your work activities as you should. Consider the environmental factors. It's important to remember that. the training is absolutely vital for you guys, manual handling, as I said already, because you need to assess the level of competence. You need to then reduce the injuries, give back advice. And of course, you need to have those legislations in place, the documentation that is required, definitely. And of course, you need to be assessing these as you go along, whether they are in date or not, or whether there's something new that has come and that you need to actually be familiarized with. Otherwise you risk the chance of being sued, and you will probably lose a lot of money, or they can even close you down. So I've said a lot, I've talked a lot. Thank you for listening, and I'm happy to field any questions. Thank you so much. No, I've done well.
You have done well, and thank you so much. That was fantastic as always. And as always, a lot of questions have been coming through prompted, but I just wanted to kind of highlight one of the comments, which I think is obviously why we do the health hour. But there's a comment to say, obviously great teaching as always, but to say that they wished that their GP or consultant had taken the time to explain things to them before they were referred to pain clinic. And that's often the situation. I think that people don't have a sense that they can ask the questions or fully understand why they've been taken to the next course of treatment. And when you do understand, it can be really transformative in your care. So again, thank you so much. So just picking up on some of the questions, one of the questions, and kind of stepping back into your great description of the spine and the different areas, the question is stiffness in the lumbar area due to issues with the spine, or is it to do with muscles in that area?
And I mean, it's a bit of both, really. I don't think it's exclusively just related or maybe restricted to just the spine. I mean, there are things like ankylosing spondylosis, which is called bamboo spine, But then, of course, if you have a bamboo spine and to that end, you do develop a watery infection, you can get pain in the back. You can get like a kidney stone, which would give you pain like that, because the nerve that gives sensation to that area is the one that supplies the inside as well. So that's something, but this is why you need to be investigated. This is why they need to do the tests, the tests that are required in order to narrow it down. Remember, when you come to the doctor, he's not just going to say, yes, you've got X, you don't have Y, you don't have Z. No, he would actually take a history. He'd actually, look at what you've done, what is this and that, and blah, blah. And then based on what you tell them, they will then decide, okay, well, let's examine you. That's the second stage. And then once they examine you, they will then come to something of a working diagnosis. And with that, they might decide to conclude, well, okay, for example, let's do a water sample, dip it. Maybe there is an infection, maybe there's blood, maybe there's protein. Or let's do an x-ray of your spine. Maybe there's evidence there of a lesion growing. Maybe there's evidence there of wear and tear, which is what you likely might find, as I say. So these are all things, but it's not exclusively just because of the spine or maybe just the muscles. It can be a bit of both, and it could be anything else, because it's what we call referred pain.
Great, thank you so much. And I have another question, and it kind of relates to what you've just said in terms of, encouraging people to seek help and investigation. And it's fantastic to have you here, and we will go through all your questions. Some of the questions I note are quite specific to people's symptoms. So I know that Dr. Kamara will give, reflections on it, but we do still encourage you to go to your GPs, to go to your doctors, to get your personal review. But someone comments about having a lower disc problem, which is pinching the nerves on the left side. The person's in a lot of pain and going to, I think, physiotherapy, but it isn't helping, and just ask for suggestions in terms of management.
Maybe you just answered the question. The question is, the answer is there. They've got pain. They've sought some remedy. The remedy is not bearing the fruits, i.e., you're not getting the success or the progress that you want to make. Therefore, as we always, the way I was brought up, if you do something So for example, someone comes in and they're short of breath. This is me digressing. Short of breath, and I give them oxygen. Yeah, I'd want to make sure that oxygen is working. Do you see what I mean? And so what I do is I reassess. So that's where this comes in. So if you've had physiotherapy and the physio is not working, why isn't it working? What has the physio said? Have they suggested anything else? Maybe you might need further management assessment, i.e. you might need a scan to see what is happening. Is it something that would require surgery or not? Is it something that could benefit from something else, or maybe a combination? For example, acupuncture, hydrotherapy, red heat, or maybe it'll be just something related with the posture, which is what you're not paying attention to. Maybe you're a bit overweight, maybe you're not moving as you should, or you have that in the family and you weren't aware of that. So now you obviously are a lot more at risk than somebody else who hasn't got that in the family. So it's a multifactorial thing, it's a multifaceted approach, and it's not just one cap or size fits all. No, it's not a panacea. It's not a silver bullet. It's something I have to individualize, and that's why I like to speak to people directly, in a way whereby it's bespoke, it's tailored to their needs. If it's not working, why isn't it working? Go back to the GP that referred you, and then they can take it a stage further. And for all you know, the answer lies there, because what we looked at already hasn't worked, and so therefore the next step might be just where we find the answer.
Great, thank you. So, no. The person says they did have an MRI, and I think it just highlights that if something's not working, you've got to go back. You've got to challenge. You're the best gauge of your body and how it's going. So definitely. And there's another question of someone that said they've had surgery on their spine, which was successful. Glad to hear. But as the osteoarthritis has worsened due to their SLE, the sciatica has set back in, and further surgery is not recommended. And I think he's just asking, will this worsen? I think just thinking about, your kind of reflections of repeated episodes of back pain, etc. Will this worsen if they don't have, because surgery isn't recommended?
Again, there's no direct or straightforward answer. The reason for that is that what's the word for it? People feel pain differently. As you know, there are, endorphins, the natural painkillers that were God-given. And so in some people it might be more, in some people it might be less. Sometimes it might even just the psyche of it. But this is why it's important. When you do develop the pain, make sure you look after it within 12 weeks. Bring it down to that level where the moment it goes beyond 12 weeks, it becomes chronic. And then there's this battle, this ding-dong battle, because the brain tells you one thing, the body knows another thing. You're feeling the pain, but the brain is saying, oh, I'm used to this. This is something I know is normal. So how do you try and de-link that is where it actually becomes individualized, as it were. Because see, some people, as I speak to you, I do have back pain myself. But the way I manage it, you'll never see me take codeine. You see what I mean? I deal with it in a different way. I stretch, I go about, do this and do that, For me to take a painkiller, well, it has to be something really bad. But some people, they just give into it like that. They take it like Smarties, and that doesn't help. Because when I do the chronic back pain, you would see what I'm talking about. Because a lot of people say opioids, and I give morphine, give tramadol, give Butrans patch and all that. They don't work. So this is the problem with it. And so you need to then think back and say, well, hang on. There is pain management, which it's a specialty on its own. It's a whole specialty, which is what they look at. They actually make a plan for you. But again, the question is, bone pain, is it because of the cancer? Or is it because of something else going on? So if I'm giving you the treatment for a pain, which is just a muscle pulled, you can't compare it to someone who's definitely got a bone lesion there. Impossible. So that has to be something that is looked at in a what's the word for it? In a progressive, calibrated manner with the GP in the middle, the practitioner in the middle, and of course the specialties, But as I say, it differs from individual to individual, and in fact, I can give you an example. there is this whiplash thing, which we all know about. Now, the science of it is that people who come from the Eastern European aspect of the world cope better with pain than the likes of us who are here. Does that make sense? That's because of the way they are. You know, psychologically, they're probably more, I'd say, in tune because they were exposed to that in their youth and things and the rest of it. And so they have developed some kind of resilience, if you like, which is far more from somebody who has never had that before and it's an acute episode. You know, there are people whose pain threshold is very low. You see what I mean? And the other ones is high. So I can't say the same applies to who's low and who's high. Impossible. So it has to be measured according to the person's needs. I don't know if I'm making any sense, but it's not something that says it's a silver bullet and therefore it works for everybody. It doesn't.
No, I think it makes perfect sense, Dr. Kamara, and I think it's a whole aspect of recognizing ourselves as individuals. In the same way we want doctors to see ourselves as individuals, we have to recognize ourselves as individuals, and how we may respond to pain is very different to others. It's funny, as you were speaking, I suddenly adjusted my posture. So your guidance is having a real-time effect. So there's another reflection which I thought was really great when you were talking about the loads, because I think that was surprising to many, because they were actually, we often lift heavier loads and we think nothing of it. And that's, you know, in a way we take our backs for granted in that way. And someone just made a comment, it made me laugh, and just saying, you know, the average suitcase load is 45 pounds, you know, and saying that they're glad they don't work in the luggage section of an airport. But it made me reflect, because every time I am at the airport, I see people of various ages and habitus jumping to pick up these heavy suitcases, and often in a really awkward manner, because you're trying to fit between people. And so it's just a reminder for everyone as we travel, you know, if we may see our luggage coming, have a bit of patience, create space, go and lift it, bend your knees so that you can actually support your backers doing that. This is a common question.
To add to that, it's not without reason that the attendants there have got a red tag.
Yeah.
So when it's more than 24 kilos, they'll put it heavy. There's a reason for that. So that whoever is dealing with it at the other end knows this is something that maybe is beyond what we should be, we're licensed for in the airline. And so therefore, it might take two people to lift it as opposed to one, because people can come back and claim and sue them and things like that. So it's important. These tiny tips, as you're putting it, is vital for people to understand that we need to protect the back. Unfortunately, we don't do that because we don't hear it crying to us, say, hey, man, what are you doing to me? You know what I'm saying? Until it gets to the point where you can't take anymore, and boom, you know.
Yeah, no, very, very true, very, very true. And there's a question that sometimes has come up in other settings about the fluid in our spine, you know, as you described it. And I think people trying to understand, you know, can it be replaced by diet or fluids? As you said, it dries up as we get older. So just to kind of explain the context of that.
I'm not sure. I know when it's worn, I think, for example, it's dried up and things. There is something what they call it cementoplasty. That's something that a lot of people would know, those who are dealing with spines, you know, when I was doing that kind of thing. But it's rare. It has to be something that is suitable for that particular individual. Again, they have to be doing it at the point whereby they know that this would be something that would benefit you. Remember, when you're doing surgery to the back, 1/3 of them you would improve. 1/3 of them will be nonplussed, like nothing has happened, and 1/3 of them you worsen. So the surgeon who's actually undertaking that procedure or that adventure needs to think what is in their favor and what is not in their favor. Because one thing I don't want to do is, why would I worsen the pain that you have already by trying to, you know, go into your back, and it's not without risk. So these are the things you have to bear in mind. You see, but clearly, as unfortunately as you go up, everything else, as they say, pardon the expression, goes south, and that's the kind of thing you get. So it dries up, but as I say, in some professions, quicker than others, and in people who have that osteoarthritis or rheumatoid arthritis or psoriatic arthritis running in their family, or gout or anything like that, clearly they're more at risk than people who are not. So it just gives you the understanding that, look, it's not as straightforward as you think, but there are a lot of things, a lot of factors embedded in that.
Great, thank you. And there's a question which I think is so relevant in this kind of not post-COVID, peri-COVID era of as the dynamics of us working from home. So someone has commented that they feel that their back health seems to have worsened since working from home more, and they had back surgery, but the progress seems to have gone backwards. And did you feel that this was due to sitting down more?
I mean, as I say, you just answered it. It's sedentary lifestyle. This is why I said we always advise. There's certain, illnesses which are ascribed to sitting down for long periods of time. It's just natural. If you were to sit down in one position for like an hour, whether you like it or not, realistically, one thing that happens is you begin to bend forward. I don't know if you know, there's a new terminology that is being coined to do with the phone, the mobile phone inception. There's the posture like that. So everybody's on their phones, and now the neck is now more lordotic than it has been in the past, say, 30 years, 40 years. It's natural because everybody's on their phones, even at dinner, outside in the community and things, at work and all that. And the sedentary lifestyle obviously causes one thing: the blood flow doesn't, flow as it should. So you have, what's the word for it? Pooling in the lower limbs. And of course, the posture that goes with it worsens the situation. Inactivity, all of that added together since COVID, clearly, it's not surprising that this is the situation. It worsens it. But with the back or with any of the injuries, the more you move, the better, especially for women. I hate to say this, postmenopausal women, they have to understand the bones become weaker. This is just natural. So therefore, the bone turnover would be better if you move. This is why they're saying, if you were in a meeting an hour or two and you sat down and not even stretched, one thing I always do is I call people and say, okay, let's have a stretch. Let's sit down, let's stop, stand up. Just, stretch a bit. And that does help one way or the other. And if you were to do that, develop that every 1 hour, 2 hours, just take 5 minutes up and down. It does help with the movement. It does help with the back. It does help with the blood flow. And it helps with a lot of other illnesses. There's no questions about that. It's a proven fact, scientifically.
Great, thank you. And the another area of back pain is pregnancy. And so someone's just asked, is there any advice on back pain in pregnancy?
It's interesting you said that. Obviously, again, depending on the size of the fetus, again, depending if there's any other comorbidities, any other factors, underlying factors that didn't come to light until the pregnancy. Is there anything else, like, for example, a water infection, which is a common thing for the women? So posture is good. Something that would help, get the back. And obviously, the amount of weight you'll be lifting and all that. All of these come together. It's nice to have the midwife to help you, with that. And if you're known to have back pain before then, prior, so pre-pregnancy, you've had that, then probably get the GP and, of course, the midwife. They will do what we call an MDT, multidisciplinary team meeting, which would help, in assessing and making sure this is tailor-made for you. It's not, as I said, one size fits all, but what it is for people. But at the end, at the bottom of all of that, the bottom line is that movement does help. There's no questions about that. But if you are moving and you are pregnant and you think the pain is worsening to the point where you're developing those red flag symptoms, then definitely something has got to give. You need to be looking after yourself and making sure you're accessing the right help as soon as you physically can do that. It's important that. So women, as you know, when they're pregnant, they're prone to all sorts of things, water infections, blood clots, because the center of gravity is now lost to the baby. The baby is now pulling forward. And of course, if you are looking at the mother being prepared naturally, the breasts get filled up, they get engorged. And of course, if there are women who I hate to say this, or at risk of being crass, but maybe they were heavier naturally before the pregnancy, and now they're even more so, then obviously you're pulling. I've seen actually some people had to have breast reductions because of the fact that the bones in the thorax were definitely so crunched together that it became a problem for the woman, and so therefore they had to do that to save her back. This is the kind of thing you get. So it has to be a continual assessment. But in pregnancy, as I say, your best friend is your midwife and of course your GP. They will come together, put a plan together, and that would help you. No questions about that.
I couldn't agree more. As someone who had awful back pain in my first pregnancy, I got help later than I should have. And when I did get the help, the strap that they gave me was transformative. And I worked, I was able to keep on working right to the end of the pregnancy. And at one point I thought that I was just going to have to stop many months before, and it just completely transformed my quality of life through the pregnancy. So fully agree. And someone's just highlighted, just on the theme of pregnancy, that, it's not just parcels and suitcases, picking up young children and babies.
Yes.
And I always say to young mothers, when they're coming in, and if you're breastfeeding or you're bottle feeding and you're twisting to lift, and then you've got another child in the house and you're doing something, those movements that you take for granted can really cause some severe pain. So again, just being mindful of movements in those settings.
Yeah, I couldn't agree more. Yeah, I mean, if you imagine the newborn nowadays, is 3 kilos, 3.75 kilos. Imagine that. Now, by the time they're a year old, and we're encouraging people to breastfeed longer, they should be around 10, 10.7, 10.5 kilos. Imagine that. You're lifting that with one arm. Clearly, something has got to give. So you've got to remember that. Preserve the back, and the only way of doing that is by looking after it. When there's nothing yet wrong with it, although there is something wrong. As I said, prevention of the future or the next episode of back pain is the best thing you can do for yourself and for the back.
Great. So I'm going to come on to complementary therapies in a second, but just before that, someone has just asked another personal medical question, and again, with the disclaimers that we said earlier, but the person says they have 2 slip discs, I think second and third lumbar region, also trapped sciatica nerves, and the pain continues, and the advice is surgery, and the person's just asking, is this the only option for me?
Not necessarily, definitely not. Surgery can't just be the only option. As I said, the only time surgery would be the only option you have available to you is when you develop those 3 signs that I talked about, what we call codoequina compression, CES, where you have the urine pouring out of you involuntarily, so you're not able to control your wee, and of course the opposite, where you can't wee, you go into retention, you block completely. And of course, if you can't feel your back passage, what we call saddle anesthesia, the sit bone, you can't feel that, it's numb. And of course, the weakness, whereby you can't lift your leg, which is sudden onset. Now, those 3, obviously, you will need to be looked into, and especially with the bladder, it needs to be operated on within 24 hours. There's no questions about that. Other than that, most of the time, not unless it was an acutely displaced or maybe prolapsed or herniated disc to the point where it's impacting the spinal cord. Remember, the spinal cord is nestling in that hole, that tube. So if he actually comes out L1, L2, that's about the end bit of the spinal cord where he finishes. Now, depending on the size of it and depending on the acuteness of it, they might choose to remove it. Nowadays, they can do it on the keyhole. They can do microscopic. They can refill it. So there's a lot of things to do. And of course, they would have considered other options like physiotherapy, exercises, sometimes injections, facet joint injections they would have considered. And if that's failing, then obviously they can then suggest surgery. But even so, they will tell you what chances you have of successful surgery. Because remember, surgery is not as straightforward as you think. There are risks involved and things and all that. So all of that would have to be assessed by the appropriate professionals or specialties. And I'm sure you would be in the center of that, because that's what we need to do. We have to make sure we involve the patients in the decision making so that we know that they are with us, on board with us, to get the best of what we're seeking to get for them. but it's not, as I say, a panacea for everyone. It differs individually, and that's why it's important to tailor make it to the person's needs.
Thank you. And so complementary therapies. So someone says they've had back pain on and off for about every 3 to 4 weeks, under 50, and is thinking of other ways to avoid painkillers such as acupuncture or another therapy, and just wanted to get your views and reflections on complementary therapies.
Yeah, they have their place. There's no questions about that. As I said, in the right hands, acupuncture, definitely reflexotherapy would help. Cupping does help. I've actually undergone that, and I've actually improved with that. There's no questions about that. In the right hands, definitely. But I wouldn't. Some people say, "Well, go to a chiropractor and things like that." Now, unfortunately, if you go into a chiropractor now, whether you tell them that you've got osteoporosis and so therefore you could fracture, the person's neck in trying to straighten the back. This is something I know has happened a few times. So it's important to actually be truthful, be honest, be open and transparent to the clinician who is looking after you, and they will then probably conduct the necessary tests to see what fits you better. But I know for certain that complementary therapy has its place in managing back pain. There's no questions about that. And for me, it's even better than loading yourself with all these poisonous substances that they call tablets and things like the pregabalin, gabapentin, you name it, and all of that. I would only suggest that if I know that probably is the last resort, because remember, people's pain thresholds differ one from the other. Some people is very low, some people is very high. And I wouldn't say somebody whose pain threshold is very high, I'd go and do this for them, when the one that is low, I'll do that. Remember, they're addictive. That's one thing. You develop, some tolerance to them. So if you were taking 2 cocodamols, 3,500, you now got to the point where you're taking not only the cocodamol, but then you have to have the Butrans patch, or maybe you have to have tramadol. Some people say you have to have gabapentin, and then you have the propranolol because of anxiety, and then of course amitriptyline to help is all of that. And as I say, if you can get by and improve your chances of a better back with doing acupuncture, reflexotherapy, cupping, massage, heat therapy, hydrotherapy, I'd say explore that first before you actually subject your body to these tablets, which, as I say, have got risks that are beyond anybody's knowledge.
Thank you. As always, such a fantastic presentation, and I'm apologizing to people because as it always happens as well, is that we have loads of questions all the way through, and then in the last couple of minutes we have even more questions coming through thick and fast, and we do only have about 2 more minutes, and so I'm sorry that we can't get to all of them, and I think there's just 1 or 2 left, and I know maybe perhaps Dr. Kamara, I can share some of the questions with you so that it can be addressed in a future presentation.
Yeah.
There was one that was mentioned about fibromyalgia. I don't know, in a closing minute before I hand over to the wonderful Michelle to give announcements, whether you have any comments on it, but it's just about back pain and myalgia, and someone comments that they've had an epidural injection and have since developed fibromyalgia, but that was a concern. So quick reflection from you would be fantastic.
Fibromyalgia, one thing I tell you what, let me put it this way. If somebody was to develop back pain, now maybe you might link it to the epidural that you had and things and all that. Who knows whether the complication hasn't stemmed from the epidural that you had. That as I said, we need to establish whether it was straightforward, was it problematic at the time or not? Did it happen immediately? Did it take some time? Because fibromyalgia is a diagnosis of exclusion. You want to make sure you've ruled out anything else that may be sinister, maybe high up there, that needs immediate attention and things like that before you can then settle for that. That's one thing I know. But of course, you have the specialists in that particular, what's the word for it? Specialty, and the rheumatologists, they have certain tests they can conduct, I urge you to actually make sure you get referred to these people. they will conduct their own tests, their analysis, their management, and they can map out a plan or a trajectory that you can tread towards getting yourselves better. But fibromyalgia is not a straightforward thing as people think. It's a diagnosis of exclusion. You want to make sure you're not missing a myeloma with a fibromyalgia. You see what I mean? You're not missing a fracture which was not picked up 6 months back because of the osteoporosis or because of the lack of vitamin D, which has been existent for like a few years, especially in our, people, and then all of a sudden it's now complicated, whereby this pain. So as I say, it's a process which is not one you would say this is it, it's like silver bullet. No, it is individualized, and I urge you to use what you have in your power, i.e., it's within your gift to actually access the GP. I know everybody's saying 2 weeks, 4 weeks, and this and that, but at the end of the day, they're the best people. If it becomes acute, we are here as an A&E department. We're emergency department. That's what we do. We deal with people who have emergencies, life-threatening ones. So if any of those problems occur, like the ones that I've flagged up for you, by all means, you always have it, within you to access us, and we will do what we can for you. We will then refer you to the appropriate specialties, and you will get seen and looked at. I can't promise that everybody will be cured or healed. Clearly, we will do what we have to do. With fibromyalgia, be very careful with that. It's not one that you'd say this person has without having undergone a series of tests. But the rheumatologist is best placed to do that with the support of the GP. Thank you.
Thank you so much. Really, really grateful. And Dr. Mohamed, lots of love coming through, and just lots of just people just be really grateful, because it's, and I think I love what it says about speaking to the realities of what is happening in people's lives. So thank you so much, and thank you to all of you for listening. And I'm going to hand over to Michelle, who's just going to bear with us for, if you could bear with us for a couple of more minutes to just hear the fantastic work that's going to be happening over the next week. Over to you, Michelle.
Thank you, Dr. Vanessa, and thank you so much for an engaging, amazing hosting today. I'd also like to thank Dr. Kamara for a fantastic, informative presentation on back pain. It was absolutely brilliant. And a big thanks to each and every one of you for joining us today, and all of your interactions, all of your questions and feedback, positive feedback. And thanks again to Dr. Kamara for all of his really extremely beneficial answers. So if we could bring up the slides, and I'll start to go through. Sorry about the delay. Thank you, Natasha. Well, I hope you can all join us next week for once again for another topic in our CATIP Health Hour. It takes place every week, same time, same place, 11 till 12:15. So please do join us, and we'll have an extremely beneficial, useful topic again next week with one of our doctors. Next slide, please. Next slide, please. Brilliant. We also have on Tuesdays our Healthy Hearts. This is delivered by Dr. Hibber, who is our nutritionist. And we've got some amazing guest speakers next week, a dietitian who's going to talk all about low carb Caribbean and African foods for weight loss. So a great subject relevant to us. And following that, there's also a physical workout with our physical instructor, Orlando. So again, great for keeping those that weight off and actually keeping extremely healthy. Next slide, please. Straight after this, I hope you've got some time. You can grab your lunch and a cup of coffee and join us for our CARN Home Office drop-in sessions. It's really valuable immigration insights. So I hope you can spare us another hour or two to join us there, or please just share it with your friends and family or anybody who you think this might be useful to. Next slide, please. And this is amazing. If you know of any organisations who are interested in this, there's a Greater Manchester Walking Fund, which will be launched on Monday, the 25th of September. There is a Zoom session facilitated by our Cairns Infrastructure and Capacity Building Manager, Lesmond, and that will be presented by Carol Pollard. So please book on that. It's a free online session. And again, some really valuable funding to get us out there in nature and keeping healthy. So if you know of any organisations, please get in touch with that. Yes, we have our civic opening. Black History Month is next month coming up. Please join us for this free event. We've got some amazing guest speakers lined up, as you can see on the flyer, and that's 6:30 to 9 p.m. at the Manchester Cathedral. If you'd like to have a stall there, please email events@cairn.org.uk to find out more. This year's theme is celebrating our sisters from the Windrush theme this year, and I hope you can join us. Next slide, please. So sorry, I think I've just had a delay. Next slide, please. Yeah, so this year we would love to see you all at our 6th annual fundraising gala. It is absolutely amazing. It's going to be at the Lancashire Cricket Club this year. We've listened to all of the feedback and we've just made it even bigger and even better. Please, you can bring, if you can gather 10 people together, you do get a reduction on the price. So please do come along and celebrate with us the amazing annual awards this year and Black History Month, which leads into our next slide. This year, we are asking for you to nominate individuals or organisations who you think deserve to be recognised and the spotlight shone on them and given an award at our gala this year. It could be yourself, it could be a friend, it could be receive, it could be anybody. So we do have a number of categories there. If you want to find out any more information, or if you know of anyone, please do email events@cairn.org.uk. All entries for the nominations must be received by the 22nd of September. But this year is just going to be so amazing. Let's get together and really celebrate our Caribbean and African heritage. It's going to be a great time. And we'd just like to thank all of our supporters and partners. We have the RAFA International Development Agency, Croydon BME Forum, Enfield Caribbean Association, and Black Health Initiative, and the Redeemed Christian Church of God. So thank you so much, and look forward to seeing you all here next week. Thank you once again. Thank you to Dr. Vanessa. Thank you to Dr. Kamara, and thank you to each and every one of you. I hope you've got some of the information down. Have a look in the chat for any links you need or any emails. So thanks once again. And goodbye.
Bye. Thank you for having me.
Welcome to our Caribbean and African Targeted Health Improvement Program, CAFIP Health Hour. The Caribbean and African Health Network, CARN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our black community. To request any particular topic, please email health@can.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.